first of all, thank you very much, Daphna and Anat, that is not here, for the invitation to participate in this meeting. I would like to express my enthusiasm from what I've seen so far. Really heartwarming to see all these amazing projects. I would like to tell you that a week ago there was the annual meeting of the Israeli Society for Eye and Vision Research, where you can see earlier stage projects, and there are so many earlier stage projects in Israel, so many young people involved in this field, really promising. Now, without further ado, I would like first to present the participant of the panel. My name is Itay Chowers. I am the chairman of Ophthalmology at Hadassah Medical Center.
I'm Markovich, chair of Kaplan Medical Center and also one of the founders of Ion Medical.
Irit Bachar, I'm the director of the Ophthalmology department in Rabin Medical Center.
I'm Noah Avni-Zauberman. I'm head of ophthalmology in Maccabi Health Services.
Thank you very much. So we will try to discuss the clinical aspects of ophthalmology, the innovative projects or the needs and limitations that we have in our profession today, and how may potentially you can fulfill them, make our work easier. And I would like to start first with the issue of medications and ask my panel colleagues, what do they think are the major needs in our profession? We've seen some answer already for some of the needs, but what would you think should be addressed in the coming years? And you have some. Please, Ali.
Okay, so first I'm glad that there's so much effort of research to the drug delivery, since, for example, the intravitreal burden of injections and the follow-up is very, very hard. So I think that the holy grail for the intravitreal anti-VEGF, if it's bringing some solution, it will be really a major revolution. And of course, also the follow-up that will ease the follow-up. And so a lot of telemedicine is involved, and also into diagnostics. I think that many things that we don't see real time, for example, infections or other like corneal infections or retinal infections or endophthalmitis, that we need to wait for the result, and I would like to see much more immediate PCR or other testing that will enable us to treat immediately and correctly. So that's my main things that I would like to see.
Thank you, Aryeh. I think we've heard about sustained release drug delivery system, and I think it is very important to go in this direction. A specific target of drops with less toxicity to adjacent tissues. And also, I believe we'll go to the path of more individualized medicine and tailored treatment to each specific disease of a specific patient. And that's the future, I believe.
Well, I think everything was already said. Thank you. Personalized medicine is very important, and also the burden on the health system is very high. So if we can treat people with longer effect and fewer injection, it will be great on hospitals, on the community, and it will allow us to pay attention to other cases as well. So I think the burden on the health system is very high now.
Thank you very much. I would like to say, from my point of view, as being, I think, the only retina specialist here in the panel, someone said, for those of you who are interested in the posterior segments, one of you was, there was such a term mentioned in one of the talks. So my point of view is that we have a major issue with durability of our treatments, as was mentioned. We also have an issue with the efficacy of the treatment, specifically talking about no inherited retinal degenerations. And I can put under this umbrella also the atrophic AMD part. We don't have really a good answer for that. There are multiple clinical trials ongoing now. Many of them are trying to target the complement pathway with a limited success. We hope that there will be new therapeutic targets, perhaps the amyloid, perhaps others. That's a field with very limited answer at this point for our patients. The issue of durability is also very interesting. A lot of excitement, a lot of new developments, including gene therapy for anti-VEGF treatment, gene therapy for anti-complement treatment that was mentioned, I think, is done in partnership with Everlades. Did I say it correctly? Yeah. And several different delivery modes for sustained delivery that may potentially work. One was already approved by the FDA, the PDS, the portable delivery system by Roche, and also the suprachoroidal approach is, of course, very interesting. Now I would like to go a little bit into the issue.
Itay, I think we'll have to focus on preventive medicine. We always say that the best medicine is the prevention. And so I think if we combine it with the AI era, we should focus on early screening and detection of diseases, and maybe combining it with gene therapy or stem cell therapy in order to prevent those horrible blinding disorders that we heard during the session.
I would like to focus really on screening and ask you, because when you think about screening and remote care, we should, I think, look at several different aspects. One is we should consider the issue of home-based monitoring and home-based screening. Second is the screening not at home, but in, let's say, a comprehensive ophthalmology office or in a family physician's office, which are not a specific ophthalmic clinic. How do you think this will be pan out in the future? Can we screen patients at home? Would we need a specialized instrument? We can use the cell phone and so on. What do you think about that?
So I would like to give my 2 cents about community ophthalmology, because I'm from a healthcare system in the community. We know that early detection is very, very important, and we work in early detection. Only in Maccabi, we have nearly 20,000 people with diabetes that need a regular checkup, and some of them are low compliance patients that don't come to the ophthalmology office. Today we offer screening with fundus photography, actually portable fundus photography, so a technician goes to the far periphery. People are coming, getting their eye screened. Also, we can put this in the emergency room or endocrinology patients or centers. It doesn't have to be an ophthalmologist clinic. And then these photos are sent to an ophthalmology, a retina center, a reading center with retina specialists, and they give the diagnosis. Of course, if we detect early sign or late sign, we offer them the opportunity to be examined, get a referral to the hospital, etc. Now we have AI. So that's the next level. So today we have AI programs that actually can replace, or should I not say replace, because that's a dilemma, the retina specialist. And we're trying to get that into the system right now. You'll probably want to talk later about the difficulties and regulations, and that's the future. I see that as the future. But it's not so trivial right now.
So I have an input regarding exactly this example, because we've done in Bellinson a study on 260 patients that were, actually they came for a visit They came for a visit in the endocrinology clinic. They are diabetic patients, and they were just, they came to their endocrinologist, and they got a fundus picture of their eye. And we used the AI company software to screen them. And we found that 30% were positive for diabetic retinopathy. And of the positive patient, 30% have been missed by the ophthalmologist that did the fundus eye exam at the community. So it's amazing. It's not very surprising, I have to say, because I think that the computer is superior to us, to human being, in the aspect of image analysis. And it's not surprising that we spoke about it, Itay, just a couple of days ago. Actually, the AI software was superior to the general ophthalmologist in the community, and that makes you think. And that's maybe even a threat to a couple of us.
As a special follow-up, like retinal images or OCT images, I think it's very, very good. But there is probably, I don't see it's easily replacing ophthalmologists in the checkup of a patient that has some complaints. We had a project of telemedicine during the corona, and it's very difficult to tell by pictures, even when you are video speaking with a patient, and to have the responsibility to tell him not to come. And also you need an ophthalmologist, and usually an experienced one, to have the patient the video and everything, so it doesn't save much. And in Israel, when the distances are pretty short, it's not a big advantage, I think. Maybe in remote areas, Australia, United States, or something like that, Mitzpe Ramon, but otherwise.
I think the promise of AI in ophthalmology was huge. We were very, very excited when the first system to autonomically screen patients with DR based on color fundus photograph was approved by the FDA. But here we are several years after that. Nothing is being implemented here in Israel, and I think also in many other parts of the world, because of multiple issues. Cost, who's going to pay for that? Actually, in Israel, when they tried to bring the first system, the click for a patient was more expensive than what the physician got from the Kupat Cholim. So it was, there was no economic model to implement that. Maybe that will improve. In addition to that, also the system does generate, or do generate false negatives. And it may overload the system with patients because they screen so much that do not have anything actually. So it's very exciting, but still we don't see that so much in the clinic. But I do want to ask you, where do you think will be the role of AI if we're talking about AI? We touched a little bit the issue of screening. Let's talk more about the ophthalmic clinic. Do you use AI today? Where do you think you're going to use it? And if you don't use it, why you don't use it?
So, like follow-up of, in our field, for example, keratoconus, if AI could see if a keratoconus patient is advancing or not, it can really replace or even maybe better than the judgment of the ophthalmologist. And also maybe if you have more or less fluid in the OCT or something like that, that I see as a major thing. Otherwise, I see AI in the development of drugs or gene therapy, but not in the regular clinic as a mode of really something that can help in the regular clinic.
Well, I personally think it's a revolution, and it's going to revolutionize our our profession. I think in the aspect of diagnosis, in the aspect of individualized treatment, in the aspect of surgery, it can help us. Like we were speaking about robotics in eye care, in eye surgery. So the robotic will have to be AI assisted. So I think in every field, it will be crucial, and it will be part of our our everyday. Yes, it will assist. I believe it. I don't think it will replace the doctors. I think it will assist the doctors. It will flag the problem. It will tell you, hey, this patient has diabetic retinopathy in this severity, or the keratoconus is progressive. Please pay attention. It will be very helpful to us. So we have to embrace it. That's my point of view.
I agree. I think AI will make us better doctors, but won't replace us. So we're going to know more and do more surgeries faster, more accurate, but the ophthalmologist is going to be the case manager and the decision making. And we have to remember that AI has its pitfalls, such as big data. So if we have ethnical groups or rare cases or things like that, AI will miss it. We need the ophthalmologist to make the decision, and there are also liability issues. So what happens if the AI misdiagnosed or a false negative? So who's responsible? Is it the AI company? Is it the doctor? Is it the health system that embraced the AI? So I think we have a way to go, but it's definitely there, and it's gonna transform all ophthalmology in the future.
And there's a big issue with confidentiality and the data security, because I know, like in Clalit, it's a big issue. Each AI software that they want to introduce to us, it's a big issue because lots of private data of the patients are driven, like the AI system is driven from personal data, and so we have to be very careful with that.
That's a real problem, and I know at least from my hospital at Hadassah, one of the issues, and I know also from other hospitals also in the US, one of the issues that we encounter with AI is that physicians kind of independently start to use AI tools to assist their work. Many times unsupervised, many times nobody knows that they're doing that. A lot of data goes in and out, decisions are being taken using these tools. This is a major issue. So far, lightly regulated, at least in our system, needs to be much more tightly regulated, and we see that it starts to happen these days. I would just again like to say my point of view about AI as a posterior segment person. We do start to use AI. We see that the major manufacturer of imaging devices for the posterior segments incorporates AI to their system. One of the interesting models, I think, is a model of an app store where you can choose the AI algorithm that you fashion and then apply that specific algorithm on the instrument that you have. We have that kind of initial or kind of a beta model or version of this app store with Heidelberg Engineering, which is a major manufacturer of an OCT device. I think this is quite interesting. It also allows you to upload your own algorithm to their platform, and then if anyone wants to use it and pay for it, then that's great. We do start to see use of AI in clinical trials. I think Yaniv mentioned that, very interesting, that they're going to use the AI in their study. But we see it also in other studies, and we use AI in our environment as well for research purposes. I just want to say that in medicine, what happened in the last 20 years, at least in ophthalmology, we used to have hard time acquiring data, obtaining information from the patient in terms of identifying pathology and so on. These days it's very easy. You just click a button and you get huge amount of data from all kind of imaging devices, and now the challenge is to analyze it, and for that AI is perfect, and we're going to use it more and more.
I agree about it. I wanted just to give an example. We just delivered 10 home OCT to our patients. We did a collaboration with Notal Vision, and we are just following patients with neovascular AMD who are getting faricimab injections. The patients, they have to do a daily OCT. Like each day they take the OCT of the retina and it is being transferred to a reading center, and that's amazing. That's a lot, but that's a lot of information. It's just 10 patients, 18 eyes. That's a lot of information, daily information that is streaming to our center. We do see that we can extend the treatment. Yes, you can extend the treatment because you get lots of information that is not valid when you do a monthly injection like automatically. But that's a significant load and burden to our system.
Let me ask you a last final question regarding the role of physicians and actually the role of other healthcare professionals in the future. So one of the things that we can talk about in that respect is robotics. Do you think robotics are going to be a reality in ophthalmic surgeries? Aryeh, can you sit on the beach and can do cataract surgery remotely? Is this something that you think can be real?
So I think that robotics can aid in surgery. For example, maybe like it was shown that you can inject subretinally with steadying the hand of the surgeon or guiding something that you can inject really very, very precisely. I don't see it like replacing even a routine cataract surgery because there are so many things that change during the surgery, and the patient is usually under topical anesthesia, he can move his head. So all these kinds of things are very, very difficult for robotics, and also there is a good solution nowadays by a surgeon. So I think that to create a robot, for example, that will do routine cataract surgery, I don't see it happening so fast, and so I think it can aid, maybe reconstruct an orbital fracture or something like that, but otherwise I don't see it so fast.
Aryeh, Foresight Roboting are cooking a robot, and actually I have to tell you, I have to confess that I operated with the robot, and I did the operation in a remote area. Like I did an operation on a pig eye, and you can operate in a remote area on like a virtual image. You use the VR, and you can complete the whole surgery, and the robot is doing it in another room. So that is happening nowadays. It will improve. It is going on. It took me more than a cataract surgery, but there is a learning curve, of course. That's just the beginning. It's happening. The revolution is here.
I think if you ask a general surgeon today the same question, he would say, well, look at the Da Vinci. So it's here. They're doing it, but it's not going to replace us. I think we will still need to be in the room, maybe have a drink or something. But if something goes wrong, I don't think that the AI can have solutions for everything. We still need to be there. But
their vision, by the way, is that one surgeon will control like 6 robots or something like this. But this is far. This is far. I think that the ratio will be 1:1 at the beginning. 1:1. Yes. One surgeon will control one robot at the beginning. So it will be robotic assisted system, not autonomous robot.
And this is what we see also with an eye, that it's a physician assisting device and not replacing. I get signals from Daphna that we have to end our discussion. So we have to comply with Daphna. Thank you very much.